Good afternoon, everyone. Before starting, actually, Dr. Rishikesh Sarkar, our Director of Neurosurgery, he was about to come for the presentation, but due to unavoidable circumstances, he couldn't come, and I have to go carry on with the presentation. And after being bombarded with a lot of good clinical material, now I am not going to talk about the MISS procedures or what we done. We are using intraoperative CT along with navigation for past few months in neurosurgery, and also for spine surgery. I'll just explain about what are the problems we had, initial problems and roadblocks, and what are the reservations we had and how we overcome that. Let us start. Acquiring a reliable intraoperative CT image has opened up immense possibility in neurosurgery and spine surgery. It confers a high degree of precision. That is what we want. MISS is all about. We use, for intraoperative CT, we use body tone by Neurologica, and navigation, we use EC-Nav system. And this is the intraoperative CT we use. It is more compact and easily maneuverable than we really thought of. We had a lot of criticisms when they said we are going to use an intraoperative CT. I was the one who was more worried about intraoperative CT. What is the difference between O-arm and CT? Why should we have an intraoperative CT at all? Whether just an O-arm is enough or not? Actually, intraoperative CT, the imaging is more clearer than O-arm. And in O-arm, you may lose the bony detail as the patient body mass index increases and image may degrade, but intraoperative CT has no limit on number of levels. The entire spine can be, it has a good field of vision, so entire spine you can visualize in a single scan. And in neurosurgical perspective, nowadays we are getting CT angiograms and perfusion studies right in the table. That is very useful for us, and also for tumors you can get contrast studies done inside the theater itself. So this is how the workflow with navigation goes. First we will take a preoperative scan before the surgery. At this time, while taking scan, the operating team need not be there inside with the patient, and we will co-register with the navigation. And after this step, we will take out the CT, and we will work only based on navigation. And after the surgery is over, we will bring in the CT for confirmation. So this is an image of intraoperative CT being taken in our theater along with the intraoperative neuromonitoring for the cases if it is required. And what is the problem with using a preoperative scan? Why do we need an intraoperative scan at all? Because in intraoperatively we put the patient prone along with a lot of bolsters, and we significantly change the alignment of the spine, right? Though the alignment changes is there across all the regions regardless of the underlying pathology. In each and every case, we should think about the shift in alignment while putting the patient prone along with bolsters intraoperatively. So this intraoperative CT-based navigation is very helpful in dysplastic and thin pedicles and spondylolisthesis and cases like this where high precision is warranted. So the seamless integration between the intraoperative CT and the navigation machine is the key factor in reducing the operating time. So first we have, as I've said already, first what we have to do is we have to calibrate both the intraoperative CT and the navigation machine, and we have to take an intraoperative scan, and after that the surgery is based only on navigation. So we use this navigation virtual probe extension feature for planning the entry points and navigating the screws. And another thing which problem we had is for training our radiology assistants and technicians. In fact, we are also getting trained along with them because there is a basic difference between an intraoperative CT and conventional CT, what they used to do. In conventional CT, the gantry remains stationary while the patient and the table moves. Here, the patient will remain stationary, and they have to give the contrast and move the gantry according to the need. So they have a quite long learning curve, and we have to be patient for getting a proper angio, perfusion and contrast studies to be done inside the theater. And initially we were used to take a lot of time. We are just using it for past 8 months. Now we can able to do within 10 minutes, we can able to do a single CT scan. So radiation dosage, we were so wary about the radiation dosage. Actually, it was so scary to think about having a CT machine inside the day-to-day operating room. But as the time goes, now we can able to take both preoperative and postoperative CT to the dosage like similar to the conventional single thoracolumbar CT. Initially, we used to take a larger dose of radiation, but now we were able to do with 1/3 of radiation what we were used to do initially. This is what I said. We can do it comfortably. Do 2 CTs within the dose of conventional thoracolumbar CTs. So we were able to do within the 1/3 of the dosage which we were used to do before initially. So radiation to the operating team is also significantly reduced because we need not be there inside while taking the CT, and it is less when compared to conventional fluoroscopy. These are the intraoperative images of MISS surgeries we did in our theater, and these are the initially we were using this intraoperative CT without navigation at all. These are the screws which looked almost perfect in a 2D CM, but when we checked with an intraoperative CT, they looked misplaced. That is what 2D CM will not always confirm the correct trajectory which we actually expect. These are the cases which we have did. And as for us, though we have very limited experience, but as of now, it is highly precise, but long-term experience is needed to see whether there is any true difference in the revision rates when compared to the conventional techniques, and difference in the complication rates, and the difference in the radiation dose, and most importantly, the cost effectiveness of having an intraoperative CT. But based on our initial experience with this intraoperative CT-based navigation, it is very promising in terms of improving the precision and avoiding complications. Thank you.